Good afternoon. Welcome to our webinar, Responding to the COVID-19 Pandemic, Challenges and Opportunities for Bicultural and Multicultural Providers. My name is Maxine Henry, the co-director for the National Hispanic and Latino Addiction Technology Transfer Center. I will be your host for today's webinar. Before I introduce you to today's guest presenter, here are some brief instructions about today's webinar. This webinar will be recorded and archived for future playback. It will also be dubbed or closed caption in Spanish and eventually also in Portuguese. A copy of today's presentation will also be made available after the webinar. The lines will be muted throughout the presentation so as to minimize background noise and other interference. When we get to the Q&A portion of our webinar, you will have an opportunity to ask questions by clicking the Q&A box in the center bottom of your screen, and I will present your questions to our presenter. We will also be asking you to fill out a brief survey at the end of this webinar. This satisfaction evaluation is important to the work we do and provides us the opportunity to improve our training efforts. Although we did not secure continuing education credits for this event, we plan to do so for future events. A certificate of completion can be sent to you upon request via email after the completion of the satisfaction evaluation. So let's begin. Let's start by introducing the National Hispanic and Latino Addiction Technology Transfer Center and our team. The National Hispanic and Latino Addiction Technology Transfer Center, otherwise known as the ATTC, is housed at the National Latino Behavioral Health Association, located in New Mexico. NALBA, as we call it for short, was established to fill a need for a unified national voice for Latino populations in the behavioral health arena, and to bring attention to the great disparities that exist in the areas of access, utilization, practice-based research, and adequately trained personnel. The mission and goal of NALBA is to influence behavioral health policy, eliminate disparities in funding and access to services, and improve the quality of services and treatment outcome for Latino populations. In order to meet our objective of providing national leadership on Latino behavioral health concerns, NALBA has chosen 6 major areas of focus: targeted capacity expansion of mental health services for Latinos, Latino behavioral health evidence-based practices, legislation to increase the number of counselors, therapists, and other behavioral health practitioners, funding for co-occurring disorders of alcohol and substance use, and the opioid crisis in the Latino community, and finally, but certainly not least, suicide prevention. The executive director for NALBA is Fred Sandoval, pictured here. Our ATTC is part of the ATTC network, which is an international multidisciplinary resource for professionals in the addictions treatment and recovery services field. Established in 1993 by the Substance Abuse and Mental Health Services Administration, SAMHSA, the ATTC network is comprised of 10 domestic regional centers, 6 international HIV centers, which are funded by PEPFAR, 2 national focus area centers, and a network coordinating office. Together, the network serves the 50 US states, the District of Columbia, Puerto Rico, the US Virgin Islands, and the Pacific Islands of Guam, American Samoa, Palau, the Marshall Islands, Micronesia, and the Mariana Islands. The international HIV ATTCs serve Vietnam, Southeast Asia, South Africa, and Ukraine. Here you will see a map of the US-based ATTCs, MH TTCs, and PTTCs. The National Hispanic and Latino ATTC has a national focus for Hispanic and Latino communities and the workforce that provides services to these communities. The mission of the National Hispanic and Latino ATTC is to provide high-quality training and technical assistance to improve the capacity of the workforce serving Hispanic and Latino communities in behavioral health prevention, treatment, and recovery. We disseminate and support the implementation of evidence-based and promising practices to enhance service delivery, promote the growth of a diverse, culturally competent workforce, and bridge access to quality behavioral health services. We are committed to increasing health equity and access to effective, culturally and linguistically grounded approaches. Our ATTC is staffed by Dr. Pierluigi Mancini, our project director. I serve as the project co-director, and Ruth Yanez is our executive administrative assistant. The National Latino Behavioral Health Association is also the home of our sister TTC, the National Hispanic and Latino Prevention Technology Transfer Center. We will provide contact information at the end of this webinar. And now it is my pleasure to introduce you to our esteemed presenter for today. Dr. Marilyn Laila Sampilo is a clinical psychologist who specializes in integrated behavioral health and health disparities among minority populations. She received her doctoral degree in clinical child psychology from the University of Kansas, a Master of Public Health with a concentration in social and behavioral aspects of public health from the University of Kansas Medical Center, and an executive certificate in social impact strategy from the University of Pennsylvania, all of which have allowed her to develop extensive experience in prevention, health promotion, and intervention for minority populations, particularly the Hispanic and Latino population. Dr. Sampilo is also well-versed in public policy from her tenure as a health equity and cultural competency administrator at the state level, where she chaired a statewide disparities and cultural competence advisory committee, led the agency's behavioral health equity initiatives, and consulted with state agencies on issues of equity and diversity, particularly related to racial, ethnic minority, immigrant, and refugee populations. She is currently a psychologist in the Center for Pediatric Behavioral Health at Cleveland Clinic, where she works in integrated behavioral health within primary care. She also works with various local, state, regional, and national entities on training and professional development in the areas of health equity, diversity, and cultural proficiency. Dr. Sampilo, I want to say thank you for coming today. It is such an honor to work with you, and I cannot wait to see your presentation. Please take it away.
Well, thank you, Maxine, and thank you for that lovely introduction. And before we begin, just a thank you to everyone at the National Hispanic and Latino ATTC, the National Latino Behavioral Health Association, and SAMHSA for making this training and so many others like it possible, especially right now in light of the COVID-19 pandemic. And to all of you who registered and are in attendance today, thank you for being here. It is an honor and privilege to be with you today and to share information that hopefully will be helpful to you in your respective work. So thank you y muchísimas gracias a todos. The title of today's webinar is Responding to the COVID-19 Pandemic, Challenges and Opportunities for Bicultural and Multicultural Providers. Before we begin, I just want to get a sense of who we all have in attendance. So this presentation is geared towards providers, but you likely represent various workplace settings. So I think we have a poll question. So which of the following best describes your work environment? We have a couple different choices, and I know that this list is not exhaustive, but feel free to select the one that best captures it or other if your setting is not captured in the responses. You might have to scroll slightly down to see the other option. So we'll just take a few seconds to capture your responses. Awesome. So it looks like we have quite a bit of you from representing nonprofit agencies, a good percentage from school or university settings, and as well as government agencies. So really we have a great diversity in terms of the workplaces and practices that you all represent. So I'm excited about that. All right. All right, just advancing slides here. Okay, so just to orient you to the presentation today, the key objectives for today are to describe the disparities in the context of the COVID-19 pandemic, outline factors that contribute to behavioral health disparities, discuss challenges and opportunities that providers face with the current crisis, and outline programs that may help address challenges and steps to take moving forward. And before we get into today's content, just another quick poll question to kick us off. Okay, so this one is a true or false question. The coronavirus is the great equalizer because no one is immune and it has the potential to impact everyone. True or false? And again, we'll give it a few seconds just to let people respond. Okay, it looks like the majority of you responded true. So we'll see a little bit how that plays out. So before we begin any discussion on the impact of COVID-19 on our Hispanic and Latino or Latinx populations, we have to address this notion of the coronavirus as a great equalizer. That because no one is immune and everyone is impacted, regardless of country, as we see its global spread, and regardless of gender, race, ethnicity, creed, etc., it is the great equalizer. And yet we see headlines such as these. The deadly price of COVID-19, racial disparities, American inequality with COVID-19, concern for widening disparities, disparate representations of communities of color in COVID-19 hospitalizations, and coronavirus impact on young people of color, even when young people were originally thought to be protected from the virus. And more we are seeing headlines specific to the disproportionate impact on Hispanic and Latinos, leaving many to wonder or question what needs to change. And hopefully this presentation will offer you some thoughts or ideas about that. And while those are just a sampling of the headlines, I wanted to review some of the data showing these market disparities. On your left, we see profound disparities by race, with Black and African American communities most dramatically affected. As you can see here, African Americans represent a modest share of the population, but represent the majority share of deaths from coronavirus. On your right, we see data from King County in Washington, which was the site of one of the initial outbreaks of COVID-19. And in King County, we see a higher infection rate for both Black and Hispanic or Latino populations compared to other populations and compared to expectations given their representation in the state's overall population. What's important to note here is that this data is mirrored in other states, demonstrating that these communities of color are particularly vulnerable to contracting the virus, experiencing complications from the virus, and tragically dying from the virus. While we see disparities in morbidity and mortality, we also see these same communities experiencing a disproportionate share of the economic burden of COVID-19. As depicted here, Hispanic and Black Americans report more job disruption, loss of employment, and financial stress. To put this in some perspective, Hispanic and Latinos have the highest unemployment rate in the US at roughly 18%, compared to the national rate roughly at 14.7%. And let me direct your attention to the lower right hand of this slide. Here we see that among respondents, Hispanics overwhelmingly reported concern about paying their cell phone or broadband bill in April. Now think about that and what that means when it comes to healthcare access at this time via telehealth or telemedicine. That is something that we'll definitely need to consider as we move forward. Those numbers regarding economic burden are consistent with recent surveys of the impact of the pandemic on health and well-being, with Hispanics and Latinos representing a greater share of those who say the virus is a threat, and even a major threat, to their personal finances, their daily lives, and their own health. And this really just reflects COVID-19 as a current threat. but we know the impacts of COVID-19 on Hispanics and Latinos will be long-lasting, with some estimating it will take a decade at minimum for this population to recover. So is COVID-19 the great equalizer? The answer is actually no. It's a little bit of a trick question, because while the virus itself may not discriminate, current society, with its long-standing and deep-rooted inequities, allows the virus to prey on the most vulnerable and those who have been pushed to the margins of society. So why does the coronavirus disproportionately impact communities of color, including Hispanics and Latinos? Well, because we live in a complex ecosystem of disparities resulting from persistent inequities. So this figure is intended to capture interconnected layers of inequities that build upon each other. At the broadest level, we think of discrimination and racism in policies that have resulted in historical injustices and legacies of systemic oppression. For example, consider the legacy of redlining, whereby communities with sizable racial and ethnic minority populations, primarily Black and African Americans, were essentially marginalized from investment, preventing the accumulation of capital and wealth. While many consider redlining a thing of the past, modern redlining is also occurring, with instances of Black and Latino families being steered away from predominantly white neighborhoods. This structural racism in housing is important, as it is a major driver of disparities due to its contribution to the racial wealth gap, as property ownership is the primary mechanism through which wealth is built and accumulated. Because racism and discrimination at the policy level perpetuates disparities, they are embedded into our various systems. So here we are talking about legal, educational, criminal justice systems, and even our healthcare system. This is where both conscious and unconscious bias comes into play. Overt and more direct forms of racism and discrimination also contribute to disparities, and consider the collective trauma and interpersonal prejudice and discrimination that Hispanics and Latinos have experienced, especially in the recent past and present, based on their ethnic minority status and intersectional identities. Moving inward, one of the major contributors for mortality due to COVID-19 has been underlying health conditions, including asthma, hypertension, diabetes, and obesity. And we, as a nation, have had a long-standing history of concentrating health hazards in poor neighborhoods, and a history of disenfranchisement through lack of investment or disinvestment in these neighborhoods, resulting in closer proximity to areas with poor air quality, toxic materials, unsafe or dangerous environments, and food deserts, all of which contribute to the disparate rates of those underlying health conditions. In cities with a history of redlining, the redlined areas today generally remain more segregated and more economically disadvantaged. We see this in the average median income for Hispanics and Latinos being lower than other racial and ethnic groups, which increases socioeconomic stress and related outcomes. Some of those outcomes include the structural barriers to healthcare, from a lack of access due to geographic distance, inadequate appointment times or long wait times for individuals unable to take time off work, to a lack of language accessibility. So with these inequities outlined, it's not a surprise that COVID-19 is significantly exacerbating health disparities. But it's not just physical health disparities or economic disparities, but also disparities in mental and behavioral health. We already have some preliminary data indicating that COVID-19 will exacerbate already existing behavioral and mental health disparities among our Hispanic and Latino population. For example, in a survey conducted by the Pew Research Center, Hispanics and Latinos were more likely to report their life had been altered in major ways as a result of the outbreak. In a survey by the Kaiser Family Foundation, more Hispanics reported the coronavirus as having a major impact on their mental health compared to white respondents. Similarly, in a recent report on stress in America by the American Psychological Association, Hispanics and Latinos were more likely to say they constantly or often feel stressed as a result of the pandemic, compared to other racial and ethnic groups. And a little more than 2 in 5 Hispanic adults said their average stress level related to the pandemic in the past month was between an 8 and a 10 on a 10-point scale. Many factors contribute to these mental and behavioral health disparities. We've covered a little bit the unequal burden on the Hispanic and Latino population, but in terms of daily stress, consider the potential exposure for essential workers, as many Hispanic and Latino workers fill many low-wage essential jobs that do not have telework options, including a quarter that serve in the service industry. I'd also like to just highlight some recent numbers indicating that 1 in 4 Hispanic and Latino individuals know someone who has been infected with COVID-19. And Latinos are 3 times more likely to know someone who has died from COVID-19 compared to their white counterparts. So let's think about that as another part of the collective trauma Hispanics and Latinos are experiencing with this pandemic. The inherent difficulty in engaging in the recommended mitigating strategies due to personal, family, and financial circumstances also drive these disparities. That may include lack of access to paid leave, causing individuals to work even when they might be sick. They may live in densely populated areas or multi-generational homes that make it difficult to engage in social distancing. And they may not have close access to grocery stores or pharmacies, making it difficult to stay home. Racism and discrimination, both in policy and in the current socio-political landscape and discourse. For example, some immigrant families have avoided public benefit programs due to changes in immigration policy and the current public charge rule. That can include avoiding COVID-19 related testing and treatment and avoiding other healthcare, included needed behavioral healthcare, due to a reluctance to enroll or stay enrolled in Medicaid programs. Besides lack of insurance, other structural barriers may include lack of awareness of available services, difficulty navigating those healthcare services, and lack of access to available services, again, due to things like location, transportation, or appointment and long wait times. Insufficient language access resources, including limited interpreter services for those with limited English proficiency, lack of perceived cultural and linguistic competence among providers contributes to discomfort, and cultural factors that influence thoughts and beliefs about mental health, including stigma. All of these are drivers of those disparities. I want to highlight just some of these factors that are not unique to COVID-19 and have been long factors in mental health and behavioral health disparities among our Hispanic and Latino population. So these include the structural barriers, language accessibility, cultural and linguistic competence, and stigma. So in fact, this data is from 2018. So in 2018, approximately 8.6 million Hispanic adults had a mental health or substance use disorder. This graph illustrates both treatment need at the time and, more importantly, gaps in treatment at that time across mental health and substance use concerns. Again, this was 2018. So you can see prior to COVID-19, the gap between need and treatment was already quite striking and indicative of the vast disparities in mental health. Now superimpose the current crisis on these numbers, and we are looking at exacerbation of these disparities in the context of an unprecedented crisis. Bilingual, bicultural, and multicultural providers have been in position to address this gap in some ways. And I want to throw out another poll question before we discuss this in more detail. So poll question number 3. A major strength of bilingual, bicultural, and multicultural providers can be language proficiency, cross-cultural communication, cultural knowledge, cross-cultural abilities, or all of the above. And again, we'll give it a few seconds to make sure everyone can log their answer. I'm excited to see how this one turns out. All right, all of the above is overwhelmingly the choice. Great job. So bilingual, bicultural, and multicultural providers have been invaluable in attempts to address these disparities and will be even more critical in efforts to help bridge this gap as the impact of the pandemic continues on. So why is that? Well, for bilingual and for some bicultural, multicultural providers, the ability to provide care in Hispanic and Latino individuals' preferred language, maybe Spanish, improves that patient or client experience. As language is a vehicle of culture, bilingual providers can also navigate cultural and linguistic barriers in a manner that is qualitatively different than monolinguals. There is also the notion that bicultural providers from diverse cultural backgrounds have a familiarity and unique understanding of culture-specific assets that provides them with the ability to work with Hispanic and Latino patients from a strength-based approach that is rooted not only in cultural strengths, but may also be rooted in shared experience. There is also a pretty substantial body of literature on the strengths or benefits conferred through bicultural competence. A comprehensive review of this construct of bicultural competence is beyond the scope of this presentation, but I wanted to highlight some of the relevant aspects when it comes to the provision of service. Individuals who effectively manage and navigate a second culture, in addition to their own culture of origin, are thought to have higher levels of cultural and social competence, increased cultural and social flexibility, and therefore may be better equipped to negotiate cross-cultural interactions, but also are able to recognize and utilize aspects of bicultural competence in assessment and treatment contexts. Sorry for the slide confusion there. So these providers may not only be particularly effective in service delivery for Hispanic and Latino patients, but may also be particularly effective in other inter and interprofessional roles. So within teams, collaboratives, agencies, departments, across institutions, etc. Bicultural competence has been viewed from the lens of business and organizations as also offering unique benefits beyond the cognitive components of bicultural competence, like cultural knowledge, to include behavioral components such as adaptability and cross-cultural communication skills. There is evidence to suggest that bicultural or multicultural individuals contribute uniquely to team effectiveness by virtue of their ability to detect and respond to culture-specific components of social behavior, their capacity for negotiating issues of diversity or conflict, and their ability to facilitate effective cross-cultural communication. So if we think about this more practically in terms of teams we may be on, we may have certain tools or skills, or may be able to offer certain tools or skills that make us an invaluable resource in promoting cross-cultural effectiveness. And if we work effectively in multicultural environments, it inevitably elevates a team's performance. Sorry, slides just sort of froze up on me. Okay, so given the impact of the current crisis on the Hispanic and Latino population, and given the provider attributes and strengths we just highlighted, it's not surprising that these providers may be faced with unique challenges in the current environment. I want to spend some time discussing some of these challenges and how we might turn some of these challenges into opportunities for growth and development. So with these already existing gaps in treatment and the mental health crisis that is emerging, and as research following disasters will tell us that mental health crisis will continue to emerge, there may be increased demands for bilingual and or bicultural providers. You may already be experiencing some of this in your caseloads, calls or requests for referrals. I know both in my own work and from my work consulting with agencies across the state, the question of free, inexpensive, and Spanish-speaking behavioral health providers comes up very frequently. So as bilingual and or bicultural providers, the burdens of this crisis in terms of service delivery may be unique. And again, you may already be experiencing it, and if you are not, you can reasonably expect to. Relatedly, you may find yourself in positions where you are asked to interpret when a colleague is in a bind with a lack of access to language resources, or you may find yourself acting as a cultural broker for patients seen in your workplace. They may not even be your patients, but again, due to demand or limited resources, you may be asked to help. And or you may just want to help in some ways that place you in these unique circumstances. With bilingual and bicultural providers representing a fraction of the behavioral health care workforce, there may be asks of those of you who are bilingual and or bicultural to help bridge the gap by providing consultation or training on issues of cultural competence with the Hispanic and Latino population. Like language, this represents an ask of your personal identity. And you have to determine, is this something I'm comfortable with? Is this ask even appropriate? So lots of things to navigate here. So how can we treat these challenges as opportunities for growth and development? Well, first, it's important to be intentional and strategic in whatever additional roles you may take on. This may require thinking ahead about how you may handle these challenges if they arise, reflecting on what you are comfortable with and not comfortable with, and where you may feel there may be conflicts or boundaries you crossed. In thinking these things through, it gives you space to shape your own involvement. You can set expectations and limits, and you can decide to contribute or help in ways that feel authentic to you. And I would argue that authenticity, feeling like you are being authentic in your professional and personal identities, is incredibly important. I want to share two personal stories that illustrate what we are talking about here. So in the first instance, when my clinic was transitioning from in-person to virtual care, they were having trouble using interpreters with the online platforms. Because of time and need, I offered to help if needed. I wouldn't normally have done that, but this was in the middle of the initial chaos of my primary care colleagues learning to use the virtual platforms, things not connecting, calls or virtuals dropping. So there was both an urge to help ameliorate stress for some of my frazzled colleagues and to help patients who were possibly getting lost without adequate communication. So helping to interpret recommendations or facilitate understanding of brief instructions seemed like one way I could help in these unique circumstances. But after each instance I helped, I just reiterated that this was unique to the current state of things and we needed to find a long-term solution. In another instance, I was sent a message by a colleague asking if I could call a family with limited English proficiency and determine their needs. This ask was a bit more uncomfortable as this was not a patient in my clinic, nor had I had any involvement or connection to. I spoke to the colleague to ask for clarification of the ask, and when it was clear that this was something that could be accomplished through other mechanisms and was not within my role, I rerouted that ask and helped them to rely on the appropriate resources for making this call. In both instances, I could have made different decisions, but I considered the costs both to the patient, the provider, and myself, and took actions that were both intentional and felt authentic to me. And in both instances, I addressed my involvement or lack thereof from also a perspective of what is the long-term solution for these issues. Sure, I could help, but that doesn't help solve the problem. So you're identifying and reiterating that there's a service gap or need, and as an agency, we should be thinking strategically about how to solve it. Relatedly, as a bilingual, bicultural, multicultural provider, you may be asked to or recruited, and in some more inappropriate cases, expected to help with efforts to address broader multicultural issues or issues of cultural competency in your agency. In this way, the ask is for you to serve as a consultant and advocate in addition to your day-to-day responsibilities. This again can be a challenge, both professionally and personally. So I'll move on, just having some trouble with the slides. I apologize for that. So again, how can we take this challenge as opportunity for growth or development? Well, again, it first starts with what are you comfortable doing? What role are you not just willing, but interested in taking on? So similar to the language broker and cultural broker example, maybe you identify gaps and needs that need addressing. One of the most important things anyone can do in promoting equity is question. Question when a gap exists and what is being done to bridge it. Question why members of a certain population are not responding to your outreach efforts. Question when or why a service may seem disadvantageous to some. It's through questioning that those gaps are brought to light. There's the saying, if it's not broke, don't fix it. But you also can't fix what you don't know is broken. So maybe you're comfortable helping to build infrastructure and supports for this kind of work. So you find other folks interested and engage in this work, and you develop committees or work groups to set goals and expectations and measure progress. One way I think bilingual and bicultural providers can be particularly engaged right now, again, if interested, is to hit the reset button on how we support individuals like ourselves in the workplace. So there are issues of recruitment and retention of not just bilingual and bicultural providers, but other providers of diverse backgrounds in behavioral health. And I think there's some great work being done in terms of trying to recruit and attract these folks to behavioral health settings. But what about the support after hiring? As providers, again, thinking long-term solutions, maybe consider what needs you have or what needs you have had in the past when integrating into your workplace. Was it a safe environment? Did diverse aspects of your identity feel valued? If authenticity and personal identity are important parts of your professional identity as well, are there supports and ways to develop those in the current environment? Asking yourself these questions and asking colleagues these questions might help you think of ways to enhance workplace climate when it comes to issues of diversity and inclusion. And I think this allows us also to move sort of beyond that checkbox of, yes, I represent a diverse background, I'm a diverse candidate for hiring, but it allows us to go beyond that and make sure that we have the supports in place once we're there to continue to promote and build our professional identity with our personal identity as part of that. So I wanted to give you a tool because when we think about championing efforts around multicultural issues, I think it's important to note that the importance of cultural and linguistic competency in addressing inequities in healthcare. And in order to address some of these issues of cultural and linguistic competence, we should have a good understanding of where we are at baseline. So we have to know where we are to know where we need to go. And without knowing where we stand, we can't formulate goals, objectives, and plans in a sustainable way. And we can't know how to measure progress or what are indicators of progress. So this tool, this is a self-assessment, and it's a great way to establish a baseline. And it is available from the Georgetown Center for National Cultural Competence, which offers a wealth of valuable information in this space. So I definitely think this is a good tool to use as a starting place for those of you maybe trying to improve or enhance cultural and linguistic competence efforts within your agencies. So another challenge may be the constraints or limitations of telemedicine. So, and as a bilingual and bicultural provider, feeling like it may be more difficult to honor that cultural value of personalismo in the absence of these in-person sessions. So how does this present an opportunity? Well, we may be able to increase reach for some, but a qualifier on reach, as I alluded to earlier, that Hispanics and Latinos were more likely to worry about paying their cell phone or broadband bills during the pandemic. So this is something that if we want to continue to expand reach, we will have to address through policy and advocacy in order for telehealth to be not only sustainable, but equitable. So we may be able to reach more with this platform. We may also be able to engage some individuals who have had more difficulty making in-person appointments due to various structural barriers, or maybe able to better engage those just more hesitant in in-person treatment. So for some, the social pressure in a one-to-one person setting may be a challenge, and telemedicine may be more comfortable, either because they are in a more comfortable environment themselves in their home, or it allows them to put some distance between themselves and the provider. It could also allow for improved patient-centered care, whereby you can also engage others who the patient identifies as important to their treatment. So for example, if it is difficult to get both parents to attend an in-person session due to work schedules or other reasons, telemedicine may be a preferred option because of increased flexibility in scheduling, or because you just have a captive audience when you're interacting with an individual at home. So you may be able to engage more of the individuals that that patient has identified as critical to their care. And because the shift to telemedicine may have been pretty abrupt for some, I know it was for us, it offers the opportunity to actually prioritize personalismo and simpatia. There is increased focus on developing rapport in a manner that we may not be accustomed to. So by virtue of that, we have permission to really emphasize those values. One thing I have found useful in that is just acknowledging upfront that this modality may not be what they're used to, and what concerns do they have about it. That helps with establishing that trust and may provide you with strategies to improve care over these modalities. And challenge number 4. This is not unique to bilingual and bicultural providers, but there are important considerations here for us just the same. I think it's imperative to highlight the fact that we as providers are not immune to the impacts of COVID-19. And this fact may hit at the intersection of our professional and personal identities. So I'll be honest and vulnerable here for a moment because I think it's important. And I'm a firm believer in the power of storytelling. So my family is a family of immigrants. Many were or are those essential workers, some with limited English proficiency. And I can't remember a time when my family home was not a multi-generational household. So when I think of challenges Hispanics and Latinos face with this pandemic, I think of them. We are them. I mentioned the challenges faced by professionals being asked to be language and cultural brokers, and yet that is exactly who I am when my family needs me to be. So it can be hard to separate out the collective suffering of our people with our own experiences and our own professional roles. So case in point, when the seriousness of the virus was first becoming clear, I worked very hard to make sure that my family, either because of limited English proficiency or health literacy concerns, understood the steps they needed to take to keep themselves safe. But I wasn't sure that they understood. That alone felt like a full-time job, having to make sure that they understood what they needed to do. And a family member of mine was hospitalized, and due to COVID-19 precautions, she had to be alone for the majority of her hospital stay. But we were assured that she would have an interpreter if needed. I happened to call and just check on her, and I heard the doctor speaking to her with the occasional Spanish word thrown in here and there. But he was not able to effectively communicate with her, but was not asking for an interpreter. Because I just happened to be on the phone, it was just timely in that way, I yelled, only so that my relative could hear me because she had put the phone down. So I yelled for her to put the doctor on the phone so I could interpret for her. So for some of you in the audience, the daily stress of COVID-19 and the barriers and burdens on the Hispanic and Latino population are things you may not only be hearing about, but are living. And that can be hard and frankly, at times painful. And that does not even include the competing other demands on us, from those working your actual job to also then becoming a teacher for your children for online schooling, to being both a colleague, a professional psychologist in your setting, or a counselor, or any kind of provider in your setting. And then maybe also being a mental health support for your frontline colleagues. All of this can be quite challenging. So again, the reframe here is those challenges may allow us to demonstrate deep empathy for our patients and clients in a way that perhaps is different than what we have experienced before. In any lived experience, providers can leverage that in their own work to better understand a patient's and client's circumstances and facilitate identification of strengths and assets, coping resources, and promote resilience. And perhaps most importantly, knowing we are not immune, knowing we face similar challenges, or understand their experience on a more salient or visceral level, we can help the patient feel seen. So now, while we just discussed several challenges the current and ongoing pandemic poses and the opportunities that they present, it's critical for providers to not overwhelm their own coping resources. Something that we as providers must be cognizant of is compassion fatigue. As a quick aside, I think it's important to differentiate between compassion and empathy. So while empathy is the feeling of understanding another's emotions or emotional state, compassion is the feeling of sympathy for another person who is suffering and a desire to alleviate their suffering in some way or address the cause of their suffering. So empathy is the feeling and compassion is the action. Compassion fatigue is relevant here because naturally we are providers, and right now we are providing care to individuals who are collectively experiencing a range of impacts and suffering. But additionally, if we are taking steps to turn some of these challenges into opportunities, we may be taking additional action or taking on additional responsibilities that can lead to burnout. So it's imperative that we as providers not lose sight of the importance of taking care of ourselves and having adequate coping resources in order to take care of others and take action to improve the welfare of others. A core or essential piece of this is knowing your limits. As discussed, no one is spared by the current crisis. We are all affected in some way, shape, or form. So for some, maybe the focus is on just being the best clinician or provider for your patients that you can be. And for some, it may be more. But given your own experience, your own personal circumstances, and your own personal current stress level, you make a decision on what you take on that also allows you to take care of yourself. Setting boundaries is also important because despite knowing or appreciating what you can manage, you may still be asked to do things or take on responsibilities or roles that push your limits. If you as a provider do decide to take on some of the challenges presented here, there are some things I'd encourage you to consider. First is distinguishing between those tasks or activities that are urgent or need to be done now versus done later. There may be asks of you that you cannot address now, but you can take up later. Know your supports and resources. So for example, are there others in the environment, other colleagues, other staff, other individuals working on similar ideas or initiatives with whom you can collaborate? And are there leaders who can help champion and support your efforts? And relatedly, don't go it alone. One, because initiatives are most often sustainable if there are others to support and leverage the work. And two, because shouldering the burden alone can lead to fatigue and burnout. So one way to do some of this work and account for your self-care is seeing where they may overlap. In 2016, SAMHSA developed a wellness initiative that focused on being healthy across various life domains, including emotional, physical, occupational, and intellectual domains, among others. They acknowledge that these various dimensions are interconnected and build upon one another. So when thinking about challenges turned opportunities, either the ones we've discussed or others you encounter, do they fit in some place among the domains of wellness? If they do, that may be one way to both work in the space and have it foster and promote aspects of self-care. Similarly, if the work gives meaning or purpose to one's life, that is a part of wellness and may be, again, where things can overlap. Additionally, when we think of coping and self-care to combat compassion fatigue and prevent burnout, it's important to have non-work related interests or activities. While our work may be our mission and align with our values, the work can be hard, and having other non-work goals may be just as important. Similarly, take stock and ask yourself, do you have a balance between activities that nourish or replenish you and those that actually deplete you? And practicing gratitude and granting yourself grace and compassion are also ways to foster healthy coping and self-care. But just a word about gratitude. There are heavy cultural loadings or cultural salience when it comes to gratitude, and most of what we know about gratitude comes from the American perspective. So while gratitude may be a positive coping strategy for many, there are likely cultural differences in the understanding, expression, and meaning derived from gratitude that should also be considered. So this is just a more concrete representation of being able to align opportunities with wellness. So this tool is basically a way of auditing your wellness, so to speak. So how this tool works is these are the 8 domains represented here. And you'll notice that there are lines or concentric circles that go from larger to smaller. There are 10 lines technically. And what you do is you sort of rate where you fall currently in that domain of wellness. Maybe you're a 1, meaning your domain of your wellness in that domain is particularly low. Or maybe you're a 10, your wellness in that domain is very high. But you sort of rate yourself among these domains of wellness. And depending on where you are, you may decide that certain ones require more of your attention, or certain ones may be ones you want to target for your own self-care. And so when I mentioned maybe, turning those challenges into opportunities, are those opportunities, or are there opportunities that maybe fit within some of these domains? When I think of that, I think maybe do they fall in intellectual inquiry or professional development, emotional resilience, social wellness? But just sort of thinking about maybe where some of the added burden or responsibilities that we may be taking on during this time, where could they also maybe fit when it comes to our personal wellness? So we've talked about the crisis possibly increasing burden on bilingual, bicultural, and multicultural providers. So what are some ways to help address this? So I want to talk about 2 models of programmatic efforts that I'm sure you may be familiar with, but want to talk about them in context of the current crisis. So the first is an effort I've been involved in for the past year. It's a regional community mental health navigator program in Ohio. So basically we've established these community mental health navigator programs in regional centers within Ohio. And the mental health navigator program serves as a central coordinating post. The individuals who are serving in this navigator role are licensed clinical social workers, and they both serve as an entity to do initial sort of intake and triage, but then also locate resources and facilitate those referrals. They also promote engagement in behavioral health care by providing callers or visitors with initial information regarding behavioral health, attempting to reduce that stigma, and then allocate resources or get them connected with resources appropriately. They also provide client advocacy. And so really the mental health navigator operates as sort of a one-stop shop. Instead of individuals having to navigate different agencies with different wait times who take different insurance, the mental health navigator really addresses all of those concerns up front because they know the resources in the community well and can facilitate those connections. What's important here is because we know that there is a dearth of bilingual or bicultural providers in the behavioral health workforce, the mental health navigator really will be useful and incredibly valuable in trying to make sure that clients or potential patients are connected with resources that make sure that they offer appropriate language services, appropriate interpreter services. So cultural brokers is a different program, and cultural brokers are intended to serve as bridges or links between individuals or groups of different cultural backgrounds. So think of them as bridging two worlds, so to speak. They can play a critical role in healthcare because they know the health beliefs and values of their cultural group membership, but they also know how to navigate the healthcare system. In this way, they can serve as liaisons between patients and providers, guides in improving healthcare access and services for their cultural group, advocates for effective delivery of services for the cultural group, mediators in navigating issues of mistrust between cultural groups and healthcare organizations that may be rooted in historical or even contemporary causes, and catalysts for change in helping organizations become more inclusive and more value-driven with issues of culture and diversity. The model developed by a professional friend and colleague of mine, Isaac Baez, and he coined his cultural broker program as a cultural ally program to emphasize both empowerment of the community and the broker operating more as an ally for the community and not necessarily individual clients. So these are just two programmatic efforts that are hoping to also bridge that gap. And these may be efforts or programs that anyone in attendance may be interested in learning more about in terms of helping build your services. So you may be now asking, okay, Dr. Sampilo, what actions can I take today? We've talked a lot, you've given a lot of good information, but what actions can I take today? Because I like to emphasize intentional action, I offer just a sample of some things some folks can do moving forward. So the first is you can engage in advocacy. So you could advocate for your agency or your institution to have a cultural linguistic competency plan as a way to concretely address disparities. Maybe that starts with a conversation about doing an assessment using the tool I showed earlier. Maybe that involves forming a work group to discuss the beginnings of a plan, or maybe that just involves talking to a leader about the idea. Whatever that looks like in your agency is likely accountable to some aspect of cultural linguistic competence. If they receive federal funding, they are accountable to the class standards. But the question is, do they have a plan? The plan is incredibly important because it makes them accountable and helps track progress and helps establish those goals and whether or not you've met those goals. You can also advocate for funding. With the economic impact of the pandemic, there are likely to be budgetary cuts and very hard decisions at all levels of an organization. What we know is that offices of diversity and inclusion or positions of health equity are critical and should be protected. You can advocate to protect those or advocate for creating those if they don't exist at your agency. And you can advocate for policies that foster investment in vulnerable communities. Advocate for building of resources and capacity for those communities. And these things are important because they hold us accountable in some ways to protect those we serve. And I think this quote captures that spirit. We cannot forget about progress and prosperity for our community. Our ambitions must be broad enough to include aspirations and needs of others for their sakes and for our own. And that's a phenomenal Cesar Chavez quote. You can also participate in community engagement. That might mean really developing an understanding of how the surrounding community or the communities you serve have been impacted by the pandemic. We have ideas, but do we have their voices in communicating that impact and identifying needs from their perspectives? You can develop partnerships in your community with agencies with boots on the ground already doing the work. Some of those agencies likely are represented by those in attendance. For example, is there a minority community-based organization that has established ties and relationships to the populations that you are targeting? And can you not only partner with them, but can you amplify their work? There are often grassroots organizations or minority nonprofits who are doing the work already. And maybe how you can best be helpful or best be of service is finding ways to support their efforts and amplifying their efforts. Regardless of what community engagement looks like, it is not true community engagement without centering communities and centering the voices of those communities. I like this quote, and it's a mantra that I try to live by. That really there should be no decisions, no expectations, no plans without the representations of the community itself. That in effect, there should be nothing about us without us. And you can also focus on centering we. This pandemic is highlighting the fact that we are truly in this together because we share this experience. We share vulnerability, and in doing so, we have shared humanity. So however you can move this message forward via your social media platforms, via your actions, via your day-to-day work, to really promote equity, in order to really promote equity, we have to live this idea that we are only as safe as the most vulnerable among us. And before we end today, one last polling question. So as I mentioned, I am very big on intentional action. So this last question has to do with that. So moving forward, one action I plan to take is 1, set goals around coping and self-care, identify gaps in service delivery for vulnerable populations, combat misinformation that contributes to disparities, participate in civic engagement, whether that means filling out the census, voting, engage in more dialogue in my workplace around diversity, equity, and cultural proficiency, engage in some other form of advocacy on some level, promote community engagement and amplify community efforts, or some other action, because again, we've just talked about just some ideas. But moving forward, what's one action that you plan to take? I'm really excited about the results. So just gonna give it a little bit so that everyone can respond. Awesome. So it looks like all of the choices have some good representation. So again, I think it goes back to showing that we can take a variety of actions, but all of these actions should be done with intentionality and strategy. So thank you for answering that question. Sorry. And in closing, however you move forward, whether that is goal setting for your own self-care, or so you can be the best provider that you can be in these circumstances, whether that is focusing on being the best support for your colleagues and family, whether that is having discussions about a cultural and linguistic competency plan for your agency or for your group, or if that means championing some other cause for achieving health equity for the benefit of the Hispanic and Latino population. However you move forward, remember that I alone cannot change the world, but I can cast a stone across the waters to create many ripples. Whatever you choose to do, no matter how small you think it is a stone with potential ripples. And with that, I thank you all for your time, your attention, your interest, and for your action. Thank you. And now I will turn it over to Maxine.
That was amazing. I could have probably sat here and listened to this all day long. This is just some great information for all of us to have. And I think, just being able to look at our own power and the way that you reframed the challenges that many of us are probably experiencing, and to give us almost permission, but definitely some options to turn them into opportunities and solutions that can be, last beyond COVID-19 is just absolutely amazing. So thank you, Dr. Sampilo. That was such a treat. Real quickly, we will have a copy of this presentation, the recording, available online in a couple of days. In addition to that, you can also download a PDF copy of Dr. Sampilo's amazing presentation. So with that being said, I'm going to real quickly just kind of flash through the references so that everybody knows that they're there. And now we're at everybody's favorite part, the Q&A portion. So again, thank you, Dr. Sampilo.
Of course, thank you.
We are going to take as many questions as we possibly can. Whatever we don't get to with the time that's left over, we'll work with Dr. Sampilo offline, and we'll create basically like an FAQ sheet, and then we'll post that online. So just that everybody knows, but we do have space for questions. So please enter them into the Q&A box at the bottom of your screen. And like I said, we'll get to as many as possible. Before I get to the questions, Dr. Sampilo, I do want you to know that throughout your presentation, people were just really applauding and thanking you for your presentation and for the amazing work that you're doing in our community. You're such an amazing representation of the power that we have.
Well, thank you so much. Appreciate the opportunity.
Of course. So the first question is from Katarina. Stated that she appreciates your comments on moving beyond the checkbox. She would be interested in hearing more thoughts on what could be done to grow the bilingual and bicultural behavioral health workforce.
I think that's a fantastic question, especially because we know that they represent a small percentage of the current behavioral workforce, and it's something that we're actively trying to increase. So one of the things is actually leveraging the current circumstances in one way. So as I mentioned kind of throughout this presentation today, everyone is impacted by the current pandemic, and young people in particular are impacted by the current pandemic and may be experiencing things like stress, anxiety in ways that they didn't necessarily experience before. That opens up the opportunity to build awareness about the importance of behavioral health and the importance of behavioral health providers. And so for those of us, in attendance today, I would encourage certainly to be talking or engaging in those discussions with young people to kind of build that workforce. And particularly if you are bilingual, bicultural, belong to diverse cultural backgrounds, whether that's country of origin or heritage or ethnicity, speaking to those individuals who represent similar backgrounds about the value of behavioral health as it's so salient right now and so almost tangible and concrete right now. Can really help build not only interest in the profession, but also kind of build that pipeline that we need to sort of be building. You can also start to partner with local universities, local colleges, community colleges, even high school. I'll use my personal experience again. I didn't know that psychology was a field until I took an AP psych course in high school, but it was really in college when I decided that I wanted to pursue a PhD in psychology. I had actually entered college as a pre-physical therapy major because that's what I wanted to do initially. And then switched gears because I was talked to by a psychology professor who just sort of opened up my eyes to the world of psychology and quickly shifted gears. So I think, being able to reach young people earlier on in their educational sort of pipeline will help build that workforce.
Thank you. Really doable tips, right? Like we know that this isn't going to change tomorrow, but by kind of helping to lay that foundation for folks is really important. And you're right. I mean, the underlying issues about behavioral health are going to become even more evident through this pandemic. Maria asked, how can a provider incorporate culture through telemedicine?
Fantastic question. Because, as one of the challenges I sort of posed there is that, do we feel like there are some limitations or constraints when it comes to telemedicine? I think one of the best ways to incorporate culture into telemedicine is to be more proactive about asking about culture. So whether that's incorporating questions regarding culture or cultural perspectives into your intake. So that can be, done over those virtual platforms, or can be done over the telephone. But I think we have to be more intentional about that because we may not be picking up on some of the subtleties that we see in one-to-one in-person interaction in the office or in the office setting, where there's just a little bit more to read. You may be just a little bit more limited in terms of what you're viewing in terms of the screen. So I think being very intentional about it. There is a tool for those of you who are doing counseling or therapy, behavioral health provision, the cultural formulation interview, which is a fantastic tool. It's available for free, but it was developed to ask some of these questions and really sort of elicit more from the patient or the client, aspects of their culture that could impact their current presentation, their treatment, both initiation and engagement, and then what they would measure as signals or signs of progress or progress or meeting goals. So utilizing a tool like that can be particularly helpful. But I think we just have to be really more intentional about incorporating culture, especially right now, because I think this is all a new experience for all of us. And so how we are experiencing this pandemic is going to have cultural loadings to it. And so being, more proactive in asking those questions and feeling like you have permission to do that, I think certainly can be important.
Thank you. Real quickly, as a follow-up to that, was an amazing answer. Can you repeat the name of that tool that you just discussed?
Sure. Sorry about that. It is the Cultural Formulation Interview, the CFI. And it was developed by a work group, a team with the American Psychiatric Association. And I think if you literally Google Cultural Formulation Interview, it's probably the first hit on Google that pops up, but it has a free PDF or a PDF you can download. There are also modules that you can work through to be trained and sort of learn how that particular interview sort of goes, and sort of be more prepared and equipped to sort of utilize that as a treatment or assessment tool. But certainly I think it's a very valuable tool at minimum, just to look over, review, and kind of see how they phrase questions, because I do think it really does elicit a lot of really good qualitative information from patients that you wouldn't normally get in a typical intake or a typical triage.
Great, thank you for that. I've looked at the cultural formulation tool, have used it in some trainings, and it actually is great to see how they've drilled down into some of the more granular levels of individuals' experience with their own culture, right? Mm-hmm. So it's a great tool. Thank you for that. How can one support their agency to getting greater access to translating or interpreting services? Do you know of any low-cost, reliable programs, or are there, specific, unique services that you have used or heard others have used in the past?
That's a great question. And I think that's a struggle that we are continually trying to address. So let me answer that question in two ways. One is the not to do's, because I think that that's something still we need to try and address. I know that a lot of agencies will rely on things like Google Translate or other sort of online quick translating material. And while that is something to offer, it is very limited in terms of the accuracy potentially, in terms of whether you're addressing issues of specific dialect of whether it's Spanish or some other language. So I do think that it's important to be mindful just of the limitations of those kinds of things. But I certainly understand if you don't have those resources available, having to rely on tools like that. But with that said, I personally don't know of any low-cost translating options that can be sort of disseminated quickly. One of the things that I think is incredibly important to do at your agency or institution is to, again, advocate for those resources. And so whether that is, maybe that's creating, because I don't have all those answers, but certainly whether that's creating a work group to sort of look at, okay, what are the different interpreter services and or translating services that are available, because obviously when we're talking about translating, we're talking about written material, and we're talking about interpreting, we're talking about in person or sort of via patient to provider communication, and so understanding maybe what are your options or your availability for that, and that may be something where if you partner or speak to and communicate with your local community agencies who work with those populations, they often have some thoughts about what's the best way to maybe handle that, and maybe also having some access to some resources to be able to provide some of that service. I know that's something that, even at the state level, when I worked for the state, we struggled with trying to make sure that we could do the appropriate interpreting and translating, but then also do it in a cost-effective manner. And unfortunately, those competing priorities are sort of always in place. But I definitely recommend sort of advocating at your own agency, but then also reaching out to community partners and seeing, how they maybe how they may be helpful in that regard as well.
Thank you. So the next one's going to be a little bit of a stacked question. So
Okay.
Nicolas, forgive me if I don't get exactly to your point, but Nicolas mentioned that in their workplace, a majority of Spanish-speaking individuals don't attend bilingual or cultural meetings because there are concerns of getting below productivity. Others have reported no motivation, and then sometimes there has been noticeable competition between the Hispanic population, and then the conversations or the discussions end up being divided. So with that kind of context, Dr. Sampilo, what are some opportunities that we can take to help address kind of the external issues around the splitting of our priorities, and then the internal issues about community not necessarily agreeing and getting away from the point or getting distracted?
Sure, great. So the first one, I think, regarding sort of the competing demands on time and sort of, expectations for productivity and how that can maybe limit their participation in some of these things. That is one of the things that when I mentioned sort of beyond the checkbox, those are the kinds of things that are really important, because one of the issues with recruitment and retention is more so on the retention side, and feeling like individuals who represent diverse backgrounds and provide services and across multiple languages, that there are different potential supports and resources that they need in order to succeed in the workplace in the way that one would expect. So there are those kinds of things that I think there are larger agency priorities that need to be addressed in that regard. But certainly, one of the things or some of the evidence-based strategies when it comes to like recruitment and retention are things like providing maybe some additional support or time reductions, sometimes in billable hours or productivity expectations, just, minor reductions as those individuals sort of onboard or as they come online, because there may be some additional time that's allocated for their work because of the services that they do provide, the unique services, whether that's in a different language, they're doing their service delivery in Spanish, providing maybe more case management because of that. There are some adjustments that sometimes need to be made, and those are some of the things that we do sort of talk about from retention strategy standpoint. To your second question, and I apologize because it just slipped my mind. Maxine, can you reframe me on the second part of that question?
Yeah, please don't apologize. I knew it was kind of a stacked question. I'm kind of getting you into it for that one. So thank you for the information about how we can kind of work on the external kind of competing priorities. Internally, what could we do to address some of the natural tension that tends to distract us from the larger conversation that would move the needle?
Gotcha. Okay. And definitely let me know if this doesn't answer the question. I think I got it. So I want to frame this from some of the experience I've had, in terms of addressing equity, more broadly. So I've worked on different work groups and different committees where there are naturally just competing priorities, and different perspectives on where priorities need to be laid or what strategies need to be implemented. And sometimes that can create, as Maxine just sort of alluded to, is a little bit of tension and potentially some conflict. And what I find the best way to sort of help address those issues is from the beginning or from the get-go is establish what the shared agenda is. So I take these lessons sort of from the collective impact framework that I really, really enjoy. And again, if you want to look that up, collective impact framework, which is fantastic for community coalitions, community engagement, things like that. But I really try and focus on the shared agenda. So we all maybe have our own individual goals or individual priorities, but at the end of the day, we're generally trying to establish a shared agenda where we can all have some needs met. And so that's where I really sort of emphasize at the front end of any sort of work group committee, what are the shared goals, and then establishing a shared agenda. And that may or may not necessarily have or may or may not address all of your identified priorities individually, but certainly is going to kind of keep individuals sort of focused on that common goal or common agenda. But I think sometimes we don't do that work up front because it's hard work, and we tend to just overlook and sort of jump into what we're going to do. And sometimes doing more work at the front end will save us some of the trouble on the back end.
Thank you. Kind of those crucial conversations, you know. So we have a question. Any thoughts on how to expand multicultural approaches for clients with co-occurring disorders, specifically mental health and substance use?
That's a great question, because I think, especially in light of what we've discussed in terms of treatment gaps for those suffering from co-occurring disorders can be even more detrimental. So one of the things is that when you think about multicultural sort of approaches with those individuals, the most important thing is thinking about providing that safe space or that environment to be able to discuss what those multicultural issues, how they may manifest or how they present when it comes to those disorders. So not really focusing on just one or the other, but really trying to understand the intersection of both of those and the intersection of culture in that piece. And so one of the things that I think is really helpful for that, and so I'm going to plug the cultural formulation interview again, because I think it actually is a fantastic way to sort of address getting at some of those multicultural issues, but then also allows the provider or the person administering that to kind of see where are the avenues or the spaces in terms of trying to utilize culture from that strength-based approach in terms of incorporating those into treatment and treatment goals.
Wow, nice, thank you. So this is, I think, an important one. Can you speak to important considerations of people who wish to be cultural allies, but are not Latinx or Hispanic in terms of background or identity, but familiar with culture through other means, such as family and friendship circles or personal experience?
Yeah, definitely. No, thank you so much for that question, because I think that's a really important one, and one I really didn't hit in the presentation. So thank you so much for bringing that up. When it comes to sort of important considerations, I think, cultural allies are incredibly valuable, incredibly important. So I want to make sure that I plug that and that I encourage that. And we need more cultural allies because from when we talk about privilege and we talk about positioning in society, individuals with privilege, we do want them to also be speaking up and also advocating on behalf of more vulnerable populations. And at the same time, the most important thing I think in being a cultural ally is amplifying the voices of those who are speaking from that specific experience. So doing both a combination of advocacy, but amplification as well. And I think that is where you sort of maybe see sometimes the tension is there's some tension with individuals who maybe speak for the group or tend to speak on behalf of the group. And they're doing it in a supportive and advocacy oriented way, but they're not allowing, or they're not that they're not allowing, but they're not empowering the other group to utilize their voice as well. So really that piece of both a balance of advocacy and amplification, and always trying to think of amplification as sort of that background voice of, am I amplifying something that currently exists? Am I amplifying the voice of this person in the room? Am I amplifying the voice of that vulnerable or that marginalized group? And if your actions are amplifying those, I think that's definitely probably the most important consideration, to have.
Thank you. Yeah, the idea about allies is, it's such a powerful connection in the community, and every voice matters, so.
Absolutely.
For everyone who had asked earlier, who was really tuned into the portion about options for translation and interpretation, Leslie offered that her agency utilizes TransPerfect for translation. So that might be one option for folks. All right, so another question. Maria would like to know, when a provider refers, I'm assuming a patient or a client,
Mhm.
when a provider refers someone to a community agency, what are some tips to connect communication between the provider and the community agency?
That's a really good question, because we do sometimes have that gap, and sometimes that can facilitate, um, whether not facilitate, but that can hinder whether that person actually seeks out or attends that initial appointment at the other agency. So that's where the community mental health navigator, or someone who sort of fits that role, is incredibly important, whether that's a patient navigator or community mental health navigator. So I'll just speak to the community mental health navigator piece. So the role of the person in that position is to actually um, create that connection. So they call the other agency, work with them on establishing the appointment, and they even check in to make sure that the individual attends that appointment. So they'll do a follow-up call. But the mental health navigator basically does the initial connection. So it's almost like a warm handoff from her position. She also provides information regarding sort of what to expect at that initial appointment, so that the patient or client is a bit more comfortable with the circumstances or the situation, and again is more likely to maybe attend that appointment or make that appointment, feels a little bit more comfortable with that in mind. And the mental health navigator also sort of addresses any potential barriers at that initial point of contact too. So the connection has already addressed whether they take your insurance, whether they offer in-person interpreting, or whether it's going to be on a Marty, like on an iPad, or whether it's going to be by telephone. So she's able to sort of prep the client and the provider. And so sometimes having that role as like a liaison is going to be particularly helpful. I know not every agency can provide that or have that, but anything that you can do as a provider to help soften sort of that referral, do it in a warm handoff, so to speak, kind of way, is going to increase the odds that the individual who has trust with you, right, who has an established relationship with you, will attend that appointment if you're able to provide any more sort of guidance and sort of facilitated connection. Even sometimes something as simple as, here's a name of an individual at that agency that I'm referring you to, who I want you to talk to if you have any issues. Even that alone can provide some element of comfort. So that's something to do. And again, I know that not everyone maybe has a community mental health navigator available to them, but it's certainly something that I would, if your agency, is looking for ways to improve, equitable access and improve engagement, and improve sort of rates in terms of show rates among some of our vulnerable populations, that's a way to do that. So it's a good potential investment in thinking about agency priorities.
Thank you. What are your thoughts, or can you give some insight as to why maybe mental health issues or disparities amongst Latino men might be underreported?
Sure.
And do you have any information about whether or not Latino men are more affected by COVID-19?
That's a great question. The second part of that question, I'm not exactly sure, but certainly that's something I can definitely get the answer to. I believe that with the COVID-19 pandemic, you're going to have more impact in terms of like essential workers. And so you may have more male representation in places like meatpacking plants and things like that. And so that could be one reason, but again, that's just conjecture. So I would certainly get that information for you. Regarding the first part of your question, the impact or why Latino men mental health may be underreported. I think it's a conglomerate of reasons for that. One is that just naturally, I think culturally, we still are battling the issue of stigma regarding mental health. There's also whether or not we recognize that what the representation of mental health symptoms is. And so some folks, may report most of those physical symptoms, but don't necessarily equate that or don't necessarily think of it in the context of a mental health concern, but rather report more things like concretely like pain, and go to a medical provider and sort of look for that medical diagnosis before potentially considering whether it's a mental health concern as well. So I still think those are things that we're battling, continuing to battle. I think in addition, there are some, cultural values that may play into this as well, besides stigma. So, machismo may be something that prevents some men from, thinking or talking about mental health. And that's not to say that machismo is a negative quality or negative value, because it's not. There are some strengths associated with that. But it also potentially can serve as a cultural specific reason that Latino men may underreport some of their mental health concerns. But again, I think it's partly lack of recognition, lack of understanding, lack of communication, maybe not even being able to communicate what exactly is going on with them in a way that sort of suggests or captures the mental health piece of it. And then also maybe some cultural value or latent values that play a role there as well.
Thank you. All right, I think we have time maybe for 2 more questions. So okay. One is, and you touched on it a little, but I think we want a little bit more information.
Sure.
How would you recommend that providers include family members during appointments, especially, telemedicine appointments?
Sure, that's a great question. I think first, and foremost, it's always important, I think, to ask the patient and the client, who is important to their care, who is important, who is not in the room. And I know we're not physically in the room necessarily because we're talking about telemedicine, but who is not in the room, who you think is important to this encounter, and keeping track of who those individuals are. And then, figuring out a way to invite those individuals into session, obviously with the client and patients, express permission. I think telemedicine, offers the ability to potentially do that more. I know, again, just from personal experience, I'm able to engage more family members because they just happen to be there when they would come to the office. They really are only coming with one caregiver or one family member. But just by virtue of the nature of that, they just happen to more either be at home due to, quarantine, or they're just at home because of the timing of the service, that it's a little bit more amenable to other family member schedules. Inviting them in, or at least starting with that conversation of who else do we need to be involving here. Obviously, that's going to revolve around the patient's perspective and the patient's preferences. And so we really want to take that patient-centered care perspective and approach to these issues. Other ways to involve family in care is sort of by virtue of, I think, taking advantage of that captive audience piece. So if they just happen to be there and the patient, again, is willing to engage them, I've said, hey, so-and-so, I noticed, we haven't really gotten your father's perspective or your mother's perspective on this. Are they home? Is that something that we could potentially, do? And surprisingly, more often than not, for the most part, some folks have been really amenable to that. And so I think it's capturing captive audience, while also, again, making sure that we respect and adhere to patient-centered preferences for who's involved in their care. And then I think, whether just always having that eye towards, is this appropriate for this patient? So there may be instances where it would be beneficial potentially to have more folks involved, but is it essential or is it important for this patient's, specific concern? And so always weighing those questions as well.
I love that that option. It's, taking advantage in a good way of family being there and familismo, but also always putting the patient first and always, letting it be their choice and letting them know how it can be beneficial, but respecting when they're not open to that is amazing.
Absolutely. And I think that's incredibly important just to tack on there. Sorry, Maxine, is just to think about that value of familismo in also generations, right? So for teenagers and for parents, it may be slightly different. And so there may be some tension or some conflict regarding, why would I want these folks involved, or of course you would want parents or caregivers involved. And so just always kind of keeping an eye on that and those generational differences or generational different perspectives as well.
Yes, I agree with you. Yes. Well, folks, we have come to the end of our presentation. Again, thank you, Dr. Sampilo, for this amazing presentation, for being willing to take 30 minutes of questions after your amazing presentation. I want to say thank you to all of our participants for not only just, coming, but also for engaging with Dr. Sampilo, for these amazing questions that are vital to our work, and for everything that you all do for our communities. Dr. Sampilo, you just kind of proved to the world that you're the rule, not the exception, and very honored to have worked with you on this project. Here on this slide, you will see the contact information for NALBA. Please come visit us, join our Juntos network to get more information about future events that we will hold. You will also see the contact information for Dr. Pierluigi Mancini and for me. If you want to request any free training or technical assistance from the ATTC, we would love to hear from you. Dr. Sampilo was also kind enough to let us put her email address out in the world. So if you all have additional questions about today's presentation and the amazing work that she is doing, she has made it okay for us to go ahead and reach out to her. One last final plug for our satisfaction evaluation. Your input, your opinion is really important to us. It really helps us guide the work that we do. Immediately after this webinar, you will be redirected to an external site. We ask that you take the few minutes to complete the satisfaction evaluation survey. One last time, thank you, Dr. Sampilo, for your presentation today and for the work that you are doing in our community. We truly appreciate you.
Thank you so much to all of you. And again, thank you all for attending as well.
Thank you. Have a wonderful day, everyone. Take care. Stay healthy.
Bye, everyone.